Good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. Today's webinar is the last segment in a four-part series exploring innovative strategies and evidence-based solutions to defy deaths of despair and lift our society from crisis. We're seeing this crisis manifest in rising rates of depression, suicide, and substance abuse, and declining life expectancy in the United States. In 2017, a person died of an opioid overdose every 11.4 minutes. Overdose deaths from synthetic opioids like fentanyl have skyrocketed since 2013. Despite significant efforts and funding support from the public and private sectors to expand access to naloxone and medication-assisted treatment, barriers to treatment remain. Is there a path to progress in overcoming the opioid epidemic? Yesterday, the Assistant Secretary for Health, Admiral Brett Giroir, reported that, according to recent CDC data, overdose deaths have now fallen 4.4% over the past year. He also pointed to the importance of collaboration between federal, state, and local government to achieve these decreases. And today we'll hear from leaders in the public and private sector who are working to expand access to treatment in their communities. Before we hear from our speakers, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene this event today, including Carolyn Myers, Kate Ellis, Caitlin Smith, Kirsten Wade, and Alexis Wing. We hope you'll take a moment to explore NIHCM's other resources on the opioid epidemic on our website and on the Resources tab in the webinar console, including our opioid infographic and our previous webinars highlighting efforts to prevent opioid misuse and expand access to evidence-based treatment. You can find biographical information for all of our speakers along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #DefyingDespair. I'm now pleased to introduce our first speaker, Carla Haddad, the Senior Advisor on Opioid Policy in the Office of the Assistant Secretary for Health within the U.S. Department of Health and Human Services. Under the leadership of HHS Secretary Alex Azar, the Assistant Secretary for Health is coordinating efforts across the department to address the crisis of opioid use disorder and overdose in America. This is one of the Secretary's top 4 priorities for HHS and a priority of the entire federal government. Carla has over 9 years of experience working in the federal government to improve access to health care services, most recently as policy advisor to the HRSA administrator. We're so grateful she's with us today to provide an overview of the federal response to the crisis, including their efforts to improve access to treatment and recovery services. Carla?
Thanks so much, Catherine. Good afternoon, everyone, and thanks again for the invitation for me to speak today. So I'd like to spend the next 20 minutes providing a brief overview of where we are today in terms of the latest data and trends that we're seeing. And I'll also spend some time talking about various strategies that the department has taken to combat the opioid crisis. I'll also touch on some of our priorities moving forward. So as you all know already, the opioid crisis is one of the most pressing public health challenges in the U.S. And while there are multiple data sources out there, the National Survey on Drug Use and Health really gives us our deepest data on the state of opioid misuse in the country. This comes from SAMHSA, the Substance Abuse and Mental Health Services Administration. And the latest data from 2017 indicate that about 11.4 million Americans misused opioids in the past year, and 2.1 million Americans had an opioid use disorder. In addition to that, we found that approximately 53% of individuals still receive their pain reliever from a friend or a relative. So really we're seeing that the extra pain relievers that are in the medicine cabinet are still a significant concern in this country. And the most common reason for opioid misuse is pain. So where are we in terms of the latest drug overdose death counts? There are, again, a number of various data sources out there. Last November, CDC released final 2017 drug overdose death numbers. And in 2017, they found that 70,237 people in the U.S. died due to drug overdoses. And among those, a little over 47,500 died of opioid overdoses. Again, this was predominantly caused by illicit synthetic opioids like fentanyl. However, in addition to that data source, CDC also does track on a monthly basis provisional 12-month overdose mortality data. And you can see the trend on this slide. So you can see that the peak was reached at about November of 2017. And then shortly after there, you see a flattening of the curve and a very slight but substantial decline. I want to make a note that this data you're seeing now is through October of 2018. Again, each month, CDC releases new provisional overdose data, and it's great timing that just yesterday, as Catherine indicated, CDC released the next batch of data, which runs through November of 2018, seeing a continuing positive trend. So while unfortunately a few of the slides I'll be showing you today focus on the October 2018 data, CDC did just release new data yesterday. So this map shows again, the percent change in drug overdose deaths from October 2017 to October 2018. So again, from that specific 12-month period, we saw a 4% decline over the 12-month period. And with the newest numbers that came out yesterday, as Catherine noted, we're seeing a continuous decline and an increasing decline at 4.4%. So again, steps in the positive direction. We also see that some states have made really good strides in reducing the number of drug overdose deaths over the 12-month period. So we see that Ohio has done a great job in reducing. They're down about 22%. We're seeing West Virginia down 8.1%, Iowa down 14.7%. So again, a lot of great work among the states. Unfortunately, we're seeing opposite trends in some other states, particularly in the western region, as you can see. And this is primarily due to the increase in psychostimulants like methamphetamine. This is especially concerning and something that the department is taking very seriously in terms of really thinking about our strategies to combat the opioid crisis while also keeping in mind some of the other emerging substances that are creating additional problems in many states. So taking a look at this slide and table kind of looks at the percent change in overdose mortality by class of drug, again, from October 2017 to 2018. So you'll see that, again, some progress is being made on some of the drugs you see. However, we are seeing a rise in methamphetamine and cocaine as well. And again, another table here looking at the percent change in overdose mortality by class of drug through that same 12-month period, showing kind of similar trends that we saw in the last slide, seeing good progress in terms of reductions in heroin, prescription opioids, and methadone. However, the synthetic opioids are still increasing and up about 11.4% from the previous year. So the provisional data from CDC indicates that there are several states that actually have more overdose deaths involving psychostimulants than synthetic opioids. And among those that we have data from, 6 of the 18 states that report this information, you can see, again, have increasing overdose deaths involving psychostimulants. So I just want to point this out again because this sort of data really indicates that some states are having more of an issue with psychostimulants than with synthetics even, and that our policies and approaches from both the state, federal, and local level need to really adapt to these emerging trends. So shifting gears a little bit, the public health crisis has really led to devastating consequences, not only including increases in opioid misuse and related overdoses, but also the rising incidence of neonatal abstinence syndrome, or NAS, that is due to opioid use and misuse during pregnancy. So NAS is a drug withdrawal syndrome that most commonly occurs among infants exposed to opioids in utero. And in addition to NAS, prenatal opioid exposure has also been associated with a number of different outcomes, such as poor fetal growth, preterm birth, stillbirth, and possible birth defects. And of course, I also wanted to remind you all about the increase in injection drug use that has really contributed to the spread of infectious diseases more broadly, including HIV and hepatitis C. In fact, we see that about 10% of new HIV cases are transmitted through injection drug use. So taking a step back a bit and thinking a bit more holistically about the issue, the Assistant Secretary for Health, Admiral Giroir, often uses this publication as a really good example. This was taken from the American Journal of Public Health, and it just summarizes very well the type of approach that we really need to be taking to address opioid addiction in America. The article really emphasizes that no single program or policy will have a large enough impact alone to substantially reduce overdose deaths. And it will require a combination of approaches and interventions through collaboration across various entities to truly make a difference in addressing all aspects of this issue when thinking about prevention, treatment, and recovery services. So now that I've given you, another kind of an overview of what we're seeing in terms of the data and the issue at large, and recognizing the scale and scope of this crisis, I want to now spend a few minutes talking about HHS's strategy to combat it. So again, recognizing the scale and scope of the crisis, in 2017, the Department of Health and Human Services developed a 5-point opioid response strategy. And these 5 points are illustrated here on the slide. So the 5 points include improving access to treatment, prevention and recovery services, emphasizing the critical importance of medication-assisted treatment as a component of evidence-based therapy. The second point is strengthening public health data reporting and collection to inform real-time response, advancing the practice of pain management to decrease the inappropriate use of opioids. And the fourth is enhancing the availability of overdose reversing medications. And finally, supporting cutting-edge research that helps us improve our understanding of pain and addiction, helps lead to new treatments, and identifies effective public health interventions. And I'll walk through, just for the next few minutes, each of these 5 points and provide a couple of examples of how we're implementing these items. So focusing on the first point, which is better addiction prevention, treatment, and recovery services. In 2018 alone, and just this past September, HHS put out historic levels of grant funding, more than $2 billion, to connect people struggling with addiction to high-quality, evidence-based treatment options, while really placing a special focus on medication-assisted treatment again. So this includes significant grants that were put out by SAMHSA. I mentioned before the state opioid response grants in particular, which provides funding to each of the states and really provides them with the flexibility to use those funds based off the specific needs of their communities and their population, focusing again on opioid prevention, treatment, and recovery services. HRSA also put out a significant amount of money towards several different programs and grants focusing on expanding treatment capacity and services in community health centers across the country. HRSA also put out a lot of funding toward a new rural Community Opioid Response Initiative, which is a multi-year initiative, again, focused on providing a suite of interventions targeting opioid addiction among high-risk rural communities, and they had a number of workforce grants that went out, really building the behavioral health workforce. So again, a number of programs and investments have been placed into overall enhancing our prevention, treatment, and recovery services. Focusing on the second point, better data, CDC does a lot of work on this front, and CDC currently provides funding and scientific support to help equip states with various tools to both track and report opioid overdoses and deaths, as I mentioned earlier, and to build and strengthen comprehensive prevention programs that include the prescription drug monitoring programs. Third, when looking at better pain management, we know that improving the practice of pain management is really critical because we see that about 3 out of 4 people who used heroin this past year actually misused prescription drugs first because of pain. So with this in mind, we have strongly supported the CDC guidelines on opioid prescribing and have implemented new checks with CMS to do what we can to really minimize improper prescribing of opioids. And you may have all seen that just a couple of weeks ago, the Pain Management Best Practices Interagency Task Force, which is a federal advisory committee, released a final report on acute and chronic pain management best practices, really emphasizing a balanced, patient-centered approach. So that's another example of some of the work we're doing in the pain management front. Fourth, better targeting of overdose reversing drugs. Regarding this piece, we have continued to emphasize in the department the importance of widespread distribution of naloxone, either by direct distribution or by co-prescription to patients who are at higher risk of opioid overdose. Just to give a couple of quick examples, we've provided support to first responders in communities, states, and tribes to purchase and distribute naloxone and develop strategies on its use to prevent overdose in those communities. And just last year, the U.S. Surgeon General released an advisory on naloxone and opioid overdose that included some essential information on, again, naloxone distribution and utilization for patients, for providers, prescribers, and the public. And finally, we're supporting cutting-edge research. NIH has done a lot of work on this front. In fact, they recently launched the Helping to End Addiction long-term initiative, also known as the HEAL initiative, with over $850 million in funding in 2018 alone that focuses on the full spectrum of research around prevention and treatment of addiction, and just getting to the root of pain itself and the cause of pain itself. And with this in mind, one of the signature NIH projects that is actually funded through the larger HEAL initiative is titled the Healing Community Study, and we're very excited about this particular initiative. Through this study, HHS recently awarded over $350 million in grants to really support a whole-of-government effort in 4 key states, in Kentucky, Ohio, Massachusetts, and New York. And the goal of this initiative is to reduce overdose deaths by 40% in select communities in each of these states within 3 years. Again, it's an aggressive approach, but it's one that we are really, excited to see, and we're very confident that, each of these states have a suite of interventions that they plan to implement and will, make progress in meeting their goals. We also understand that to effectively address the crisis, communities really need to be engaged. So this includes not only doctors and nurses and the health professionals, but also cops and teachers, mayors, parents, coaches. It really takes a whole of community approach, and we think that this is really what the Healing Communities study is trying to get to. So while this crisis, was decades in the making, and of course will require a strong commitment, continued commitment for many more years. I do want to share just a few positive indicators that our efforts are having a substantial effect and that we've made real progress from a public health perspective. So in terms of decreasing opioid prescriptions, we saw that from January 2017 through April 2019, our initial market data suggests that when looking at the total amount of opioids, which is measured by the morphine milligram equivalents, or MMEs, when we look at that being prescribed monthly, we've seen that it's dropped by 31%, which is significant. This success has also been achieved while the administration has continued to emphasize the importance of appropriate prescribing of opioids for patients who experience pain, and supporting the use and development of non-opioid treatments. Taking a look at naloxone prescriptions, we've seen that, again, from January 2017 to April 2019, we've seen a 484% increase in prescriptions dispensed by pharmacies, also a great outcome so far. And when thinking about treatment, we see that the number of unique patients who are receiving buprenorphine monthly from retail pharmacies has increased by 29%. So again, buprenorphine is one form of MAT, medication-assisted treatment. And we're seeing similarly that the number of naltrexone prescriptions per month have increased by more than 62%. So again, these are all, again, positive indicators that some progress is being made, and of course there's much more to do, but this gives us some hope that what we're doing is truly making a difference. So as we look forward to the next year, we have several priorities that we will be focusing on at the department level, and I just want to highlight a few of them. First, I've mentioned this a few times, especially in the data overview slides, but it will be really critical to broaden our focus, not only to continue to address the opioid crisis itself, but also to address the resurgence of methamphetamine and cocaine before we feel that they are going to become the fourth wave of the overdose epidemic. This is really important to the department, and we're committed to taking this on. We'll also continue to focus on, again, that whole of society approach to addressing opioid addiction at the community level, working closely with our state, local, and tribal partners, and the Healing Communities Initiative is one great example of that. And of course, the recent passage of the massive opioid legislation that was passed this past October, which is called the Support for Patients and Communities Act, will help enable HHS to continue to build and expand our programs that align with the department's 5-point strategy. And more broadly, I think this one is a really important one. We have to transition away from a crisis framework into a more integrated, sustainable, resilient public health system for preventing and treating substance use and other behavioral health disorders. So this is kind of more of our long-term focus as we think about what we've been doing today and how we transition into that to a more sustainable approach looking ahead. So when I say that, one item we talk about quite a bit is reimbursement and thinking about how we can better align reimbursement so that people can get paid for the right therapy. CMS has done a lot of work in this area, and we look forward to focusing in that space more in the coming months and years ahead. So just quickly, a few other priorities for the year include encouraging the expansion of comprehensive syringe service programs. We know they're very effective, and we want to continue encouraging that moving forward, enhancing emergency room, medication-assisted treatment, and ensuring warm handoffs following an overdose, and improving MAT during transitions into and out of the criminal justice system. So what I've discussed this afternoon are just a handful of initiatives at the federal level or supported by the federal government that will help tackle the opioid crisis across our country. Again, I do want to be clear that this victory is not going to be won by the federal government alone. The common theme here has been the importance of collaboration and a whole-of-society approach. And I do really feel like only by working together will we be able to fight this public health crisis and also just be able to lay a foundation for a healthier nation ahead. So with that, I want to again thank you for having me, and that concludes my presentation.
Thanks, Carla, and thank you for your leadership and for HHS's leadership and commitment to this whole community approach to combat the opioid crisis. You highlighted many of the agency's efforts to expand access to treatment. And just for our audience, if you haven't checked out the HHS opioid website, Carla had a link to it on one of her slides. It's also a great resource for more information and also for finding treatment options as well. Next, we will hear from Dr. Ken Duckworth, the Blue Cross Blue Shield of Massachusetts Medical Director for Behavioral Health. In this role, Ken leads Blue Cross's strategic efforts in the areas of mental health and substance use disorders. He previously served as both the Chief Medical Officer and Acting Commissioner for the Massachusetts Department of Mental Health, and as part of his role at Blue Cross, he volunteers to see patients in the Department of Health's Early Psychosis Program at the Massachusetts Mental Health Center. He's trained in adult and child and adolescent psychiatry and is an assistant professor of psychiatry at Harvard Medical School. Blue Cross Blue Shield of Massachusetts created groundbreaking programs that expand access to care for people with opioid use disorder and provide education and other resources to reduce the stigma associated with opioid use. Their innovative efforts have inspired actions by other stakeholders across the country, and they were recently recognized for their community-wide approach to combat the opioid epidemic with a prestigious award from the Blue Cross Blue Shield Association. Ken has been leading many of these efforts, and we're so grateful that he's here with us today to share this work. Ken?
Good afternoon, and thank you for having me as part of this important conversation. So just a little more background on myself. I'm a child psychiatrist, adult psychiatrist, and I have done work in addictions and in the population with serious and persistent mental illness and community mental health. And I prescribed Suboxone for years as part of a dual diagnosis treatment team. I've then gravitated to policy discussions and jobs because I think there's a lot that can be done on the system level. And so I joined Blue Cross Blue Shield of Massachusetts, which as a provider I felt was a very progressive health plan, and I was delighted to join the team. Since I've been at Blue Cross, I've been trying to work the problem of making access to treatment for opiate use disorder and access to treatment for mental health disorders, which are commonly co-occurring, a big part of my role. I want to take a minute to tell you a little bit about Blue Cross Blue Shield of Massachusetts. So we're a health plan, it's a nonprofit. We're based in Massachusetts. We have about 3 million members through a variety of accounts across the state. And we, of the 3 million people, about 1 million of our people that we insure live in other states. So if you took a job with a company that was based in Boston, for example, and they had a satellite office in Boise, Idaho, we would be providing the benefits for the individuals who happen to have the plan in Idaho. So it's mostly Massachusetts, and I've traveled my whole career in Massachusetts, but I do want to emphasize that some of our policies do have impacts on people in other states. So I'd like to take your attention to the first slide, which is the Blue Cross Blue Shield Massachusetts public health approach to the crisis. And I think this will echo what you've already heard. We frame it slightly differently, but I think in essence, we're trying to work to row the boat in the exact same direction. On the prevention side, Blue Cross Blue Shield of Massachusetts was very early to the conversation of making it difficult to overprescribe opiates. This was in about 2011, 2012. And I want to emphasize that this was not greeted with cheers. We were very early on to take a look at how the health plan, as part of the ecosystem, could reduce overprescribing. And we went through a process with physician groups and physician leaders, and they got on board. And we had made some decisions to make it difficult to prescribe more than 14 days of an opiate, to make it very difficult to prescribe a long-acting opiate. We exempted categories of prescribers, such as oncologists and a few other subspecialties, just to make it clear that we do appreciate some people actually need opiates. But the idea that there was many extra pills floating around which were ending up in medicine cabinets and causing vulnerabilities was well known to us. Briefly, the governor of Massachusetts signed into law a few years after we started this initiative, an even more restrictive idea, limiting prescribing to 7 days. And for our own data only at Blue Cross Blue Shield of Massachusetts, we reduced over 20 million doses of opiates compared to the same amount in prior years. And that's simply from working with the professional societies and placing some corridors on how much you could prescribe without talking to us. And this is the traditional use of a utilization management tool that I think, was one of the initiatives to curb overprescribing. We are, of course, still evaluating every other option on the pain management scale, because it's difficult to take a tool away from a physician who wants to do good for people. You have to really think comprehensively about the other alternatives. So it's a pretty long list, from lidocaine patches to TENS units to Neurontin. It's a fairly long list, and we did a review of all of our treatments, making sure that it was easy to access these other treatments, that the copays were sensible, and that our policies were engaged in a way that we weren't simply making it difficult to access a pain treatment. We were trying to provide sensible alternatives. We're actively reviewing acupuncture to be a possible benefit right now. The literature on acupuncture is not as overwhelmingly clear as it could be. However, there are some studies that are indicative that it may be of import for some people to provide an alternative to pain. And I do want to mention, outside of the traditional roles of the health plan, we've invested in a program in the community called Drug Story Theater. This is all on the prevention idea. These are people who aren't Blue Cross Blue Shield of Massachusetts members. These are middle schoolers. And a brilliant child psychiatrist named Joe Schrand, who was on the show Zoom on PBS, some of you may recall, he developed a psychodrama theater program where kids in recovery get on a stage and do a presentation to middle schoolers throughout many communities here in Massachusetts, and then they take questions from the audience. And the program is poignant and compelling and has some data that kids appreciate, that certain things are addictive, that certain things require early intervention, and that certain things require conversations with parents. So that's in the prevention space. This is what our health plan has done. And as was stated earlier, I want to emphasize the health plan is one piece of the ecosystem. But I think if we're all rowing the boat in the same direction, we're going to have a better chance together as a society to end this crisis. Intervention is how we think of the use of Narcan. I was visiting family in Philadelphia perhaps a year or two ago, and I read an article in the Philadelphia Inquirer that librarians in Philadelphia were reversing overdoses because Philadelphia has had a particularly compelling strain of heroin, and many people were traveling to Philadelphia, it reported in the story, and ending up in the bathrooms of the public library. I reflected on this and realized that I worked for a very progressive health plan that would work with many ideas that I would put forth. And I said, I'd like to really take a look at how we're addressing Narcan as a as a benefit and what we could do to get more Narcan out there. So the first thing we did was we reviewed the copays for Narcan. And I will just say for Blue Cross Blue Shield employees, I have insurance through my job, like most Americans. My copay was $50. We reduced that to $0. And most people don't know that you can go to any pharmacy in America without an order from your doctor. You don't have to ask. There's no administrative burden. You can simply get Narcan. And in Massachusetts, the pharmacist is supposed to give you a 5-minute training. I was not giving any training, but I happen to be a physician who has administered Narcan in my day. So it occurred to me that if you got it to $0 copay and you structured a way to train people to administer Narcan, that we could increase the amount of Narcan in the commercial space. Then it occurred to me that we could work with creative employer groups. Many of you know the construction industry has very high rates of opiate use disorder and overdose deaths. The construction industry in Massachusetts has been very hard hit by that. And we approached several of our accounts in this space, and they were incredibly interested in teaching the foremen on their construction sites and their employees how to use Narcan. So we created a Narcan toolkit, which I'll show you in a future slide. We also did it to some of the towns of cities of Massachusetts. And these have been hard-hit rural communities and communities that are really trying to figure out, you know, if you had Narcan in your libraries, where you have public bathrooms, if you had it in municipal buildings, you had more people trained, there could be an improved access to treatment and also an awareness and consciousness. One of the things we also did is we showed the toolkit to our Blue Cross Blue Shield of Massachusetts employees. So let's say we have about 3,000 employees. We thought we would have 4 small sessions of 25 or so people. We don't have public restrooms. We don't have construction industries. So 2 of the best use cases for Narcan would not seem to be apparent for Blue Cross Blue Shield of Massachusetts employees. But we wanted them to know what we were doing with the construction industry and with the cities of and towns of Massachusetts. And we were impressed that 300 people came. We had to keep rerunning the sessions because people wanted to know what we were doing. They had heard that our organization had been a progressive leader in this field, and we had not won that award that you mentioned from Blue Cross. People did have a sense that we had some nice momentum going, but many people wanted to get trained for people that they loved. And I was very moved by this, the idea that office workers, you know, were living with people or loving people who had an opiate use vulnerability, and they wanted to be prepared to use Narcan. So that program has been well received, and with the copay of $0 for Narcan, we are seeing a substantial increase in utilization. When I talked to the company that makes Narcan, Adapt Pharmaceuticals, they described a phenomenon which I had never heard of, which was called medication abandonment, which is when people go to the pharmacy and ask for a medicine, they learn that the copay is too high and they leave the medicine there. And we, of course, have eliminated that problem by having a $0 copay. So for our fully insured and for our self-insured accounts, you know, you can get Narcan at no charge. I'm going to come back to that toolkit a little bit at the end, but I just want to go through what we've done on the treatment side. So we do think medication-assisted treatment is one and not the only essential element of treatment, and we've done a lot to advance the cause around medication-assisted treatment. We removed the copay and the deductible where allowed by law for methadone. And the use of methadone has gone up 5 times since we've made that change. I've spoken to several other health plans who are instituting methadone benefits. Methadone is not a benefit for every health plan across America. And it's just a good example that if you're giving a person a treatment every single day and you have a daily copay of $25, the cost becomes prohibitive quite quickly. We also eliminated the copay for Narcan. As I discussed, we've seen a substantial increase in utilization of that. And for Suboxone, we removed the prior authorization for 16 milligrams and under. I happened to be at a substance use disorder clinician meeting when the email came through, and it's very rare in a health plan to have people hug you and cheer what you've done. And that was my experience that day because, you know, filling out paperwork and having a prior auth is a burden on providers, and we need the providers to take care of people. And we made a decision to remove that prior authorization. We also have an in-sourced behavioral health team at Blue Cross. So that means we have our own doctors, psychiatrists, psychologists, social workers, licensed mental health counselors. One of the things we do in treatment is we have relationships with all of the major detoxes here in Massachusetts. And our case managers know the people who run these detoxes, and we call and we say, is Ken there? We happen to have seen a claim that Ken has been admitted. And they'll say, well, let me see if I can get Ken on the phone. And the idea is that our relationship with the detox providers enables our members to speak to our case managers to see what we can do to promote their recovery. And what is the next step of care that they might need? What kind of supports might they want? Do they have a therapist? We removed all the paperwork burden for outpatient psychotherapy at Blue Cross Blue Shield of Massachusetts, and we've seen a substantial increase in the utilization of outpatient psychotherapy. Again, I see mental health and substance use disorder as frequently intertwined. So how we're thinking about our benefits on the mental health side impact people on the substance use disorder side. On the recovery side of the equation, of course, recovery is a process. It's individualized. For some people, it will involve work, family, faith. For other people, it may simply involve medication-assisted treatment. You know, it's really different, I think, for each person. I've been very impressed by this. But one of the things we did is we gave $1 million of grants to 10 organizations across the state who have recovery coaches. We're trying to gather data. What have you learned from the recovery coaches that you have? How can you let us know how many people you can take care of? Are you following outcomes? How long do your recovery coaches stay in their job? What kind of continuity can people have with their experience? And we're doing this as part of a larger effort in Massachusetts to evaluate whether peer recovery coaches could be third-party reimbursable. I happen to sit on the Governor's Commission for peer recovery coaches, and we're actively trying to sort the questions of who could be a recovery coach and how could that be third-party reimbursed. Now remember, when you're a commercial health plan, you're spending other people's money. And when an account says, you know, I'm writing this check to you to administer this benefit, they want to make sure that there'll be quality and safety that will be administered as part of that. So this is kind of how we're thinking about this in the Massachusetts Peer Recovery Coach Commission. Our grants from Blue Cross to the 10 organizations were an effort to gather data, but I think the larger question that we're facing with the workforce shortage that we have in Massachusetts, despite the fact that we have a large number of training programs in medicine, psychiatry, psychology, we produce a lot of clinicians. I mean, Boston is essentially, you know, an academic center in medicine. But we still feel that we have a workforce shortage in terms of some specialized areas of care. And one of the ideas is, could peer recovery coaches supplement, not replace, the current system of care? And so we're actively looking at that piece of the equation. Just to take a look at the next slide, I just want to show you this little toolkit that we put together. Again, this idea was borrowed from librarians in Philadelphia. And, you know, when an account came to us and said, we want to train our foremen or our librarians in our city of or town of, or for Blue Cross employees themselves, this toolkit opens up. It's a size of a kind of a makeup kit. I think is a reasonable comparison. It has 2 doses of Narcan, information on how to identify someone who is overdosed. Obviously, to call 911, we are not trying to replace the highly functional emergency medical system. We're trying to supplement it. And some basic information on how to administer Narcan. We've hired people from the Department of Public Health's overdose response team to train our accounts in this pilot. And to look at the next slide, we've also created a website for people who want to gather more information about their benefits at Blue Cross, what residential and inpatient programs are in network. It's virtually everything in the state. What people want to know, where do I go, where do I turn to? And we have the video from the Adapt Pharma on how to administer Narcan. Because again, I was impressed when I went to my local pharmacy that I did not get trained to use Narcan. And we thought it was important to put this out there. This website is publicly available. There's no need to be a Blue Cross member. And, I encourage you to take a look at it, take from it what you think is valuable, amend it for your own purposes. There's no intellectual copyright here. We're all trying to advance the ball on this important public health problem. So I'm going to stop there. Again, I just want to say the health plan is one part of the ecosystem. I'm interested in the audience's thought about other things we could do. I think we're pretty actively reviewing what we have, how we're trying to advance the ball as a community, but I'm always open to learning, and I want to thank you for your attention, and I want to thank this organization for putting together this important talk and for inviting me. Thank you.
Thank you so much, Ken. Your efforts are really moving the needle to address the epidemic, and we look forward to seeing the results of the Recovery Coaches pilot program and to really continue to help guide people on a path to recovery. Our last speaker, Hemi Tewarson, will share how governors and states are working together to approach this epidemic. Governors are at the forefront of efforts to curb the opioid epidemic and its related challenges, and the National Governors Association Center for Best Practices team has been leading efforts for several years to share best practices and strategies to address this public health challenge. Hemi is overseeing many of these efforts in her role as the director for the National Governors Association Center for Best Practices Health Division. She has decades of experience in healthcare policy in the public and private sectors, serving as senior attorney for the Office of the General Counsel at the U.S. Government Accountability Office, and in private practice as a health policy attorney. Hemi, thanks for being with us today to offer a state perspective and share NGA's efforts, and I'll turn it over to you.
Great. Thanks so much for having me, and it's really a pleasure to participate in this webinar. So I will talk quickly because I know we're running short on time, and I want to be sure there's some time for questions from the audience, since I see there's quite a few. So just very quickly for you all who are not familiar with us, the National Governors Association is completely bipartisan. Our current chair is Governor Bullock from Montana, and our vice chair is Governor Hogan from Maryland. And we've been around a long time. This picture is the first time the governors convened in 1908. But I'm going to keep going because I'm going to talk about opioids today. Go to the next slide. One thing I do want to point out about our work is that we work, so I lead the health division, but we work in complete partnership with our public safety, Homeland Security and Public Safety Division, because really the public safety folks have been on the front lines of seeing what's happening with the opioid epidemic. So we really make sure that all of our strategies when we work with state leaders and with local communities really encompasses both the health side as well as the public safety side. So I just wanted to be sure to share that with you all. Great. So I'm not going to talk too much about this slide because I think Carla did a wonderful job with the data that's really identifying where we are going on this epidemic. I did want to just reaffirm that we are seeing this directly from the states. Certainly states are seeing synthetic opioids really taking off in terms of the deaths, as well as the psychostimulants that are mixed with the synthetic opioids. And so that's really going to continue to be the challenge, especially for our states out west. And I think their question is, how do we think about, the opioid money that we're getting from Congress and thinking about redirecting it to these new challenges? So I think that's going to continue to be a conversation from a policy perspective. Okay, so just to give you a little bit of sense of kind of where we've been in the National Governors Association working with governors on this, we've really been working on this since 2012. Governors have been, unfortunately, having to lead the charge on this since that time. It continues to be a priority in their state, even with the, the new substances that are coming into play. And one of the things we did in response to that was the governors signed a compact to fight the opioid epidemic in July 2016, and they asked us to come up with a roadmap. And so if you're interested, this is on our website. It really is about how states should think about strategies across the three spectrums of prevention, treatment, and recovery. And I think, Ken just provided some really good insights on kind of what he's seeing from the plan perspective in Massachusetts. And Carla, of course, looking at the federal strategies, and we all are working together on this, but we are certainly focused on how states can partner with all these different entities to figure out a way forward on these challenges. Okay. So I wanted to just show you where we are with states, where we have been, where we are going in terms of state work. And I'm not going to be able to have time to talk through all of these, but I thought we could highlight a few of them for you. In our work with states, I don't think any one state has solved this. But what we have tried to do in our work is highlight where are places where states really need additional support, and are there models within those areas. And so what I thought I might do is just talk about a couple of these. One is how we've been thinking about improving access to addiction treatment in rural areas. Another big area that we are working on is how we really get medication-assisted treatment for justice-involved populations. So I'll talk a little bit about our work on that. We are doing a heck of a lot of work on addressing infectious disease-related substance use, so I'll talk about the projects that we've had going on there. And then how do we really think about non-opioid pain management? So, I think Carla touched on, and Ken as well, about sort of script limits and thinking about how to, on the prevention side, really, get a better handle on how these are being prescribed in the forefront. But then the question is, there are people with chronic pain, and what are those alternatives to treatment? And we've certainly heard from different folks with pain and pain advocacy organizations that have really been clamoring and saying we are not getting the help that we need, and so what are the alternatives? So I did want to talk a little about the work in that front. Okay, so what have we been doing for addiction in rural areas? So in our project that we highlighted for other state leaders, we really looked at New Mexico. And I wanted to spend a minute talking about New Mexico and their work through their TeleEcho project. We hosted a learning lab with 3 states so they could learn about what New Mexico is doing, and they have been working on this since 2005. And what's really, I think, helpful to understand about what New Mexico is doing is they realize they don't have enough behavioral health providers to actually get those folks across their states. And so what they need to start relying on is what are video conferencing technology and clinical management tools that can be beamed out from a hub, essentially, where they have all the expertise to those rural areas where they don't have that expertise. And that's really what they've been doing. Since their initiation, there have been 950 patient cases that have been presented in the virtual clinics and 9,000 hours of CME logs. So certainly been significant uptake of this strategy. And they've also really required their Medicaid managed care organizations to get involved, paying specialists with per member per month funds, and also recognizing the role of the primary care physicians who present. Okay, medication-assisted treatment for justice-involved populations. So Massachusetts, so Ken, your state, was the state that we modeled for this. And really, there is a reentry initiative that's a partnership between the Department of Corrections and the Department of Public Health in Massachusetts. And it was implemented in 2014, and as it has really increased access to community-based MAT, especially from those coming out of the prison systems to communities. We brought 8 states to learn about what Massachusetts has been doing, and really I think there is now a new movement towards inducting treatment upon transition into facilities post-arrest, so really making sure to get the treatment to folks when they're coming out of the facility so they don't go back in, because it really is a revolving door. One of the things I did want to highlight, because of the interest in this topic, we are doing more work now, actually this week, where we're hosting trainings with 9 states to help implement action plans around MET in correction settings, especially focusing on continuity of treatment and care linkages to social support services and communities. So if you're interested in that, there will be more work coming out from NGA and the states on that front. Okay, infectious disease. So that has been a big topic for us. Injection drug use drove a 350% increase in hepatitis C between 2010 and 2016. So we really saw a need to really do some work on this. Kentucky was our model state, and they were the first southern state to authorize comprehensive harm reduction, which included syringe exchange. And now syringe exchange programs have been approved in 60 of Kentucky's 120 counties. Pretty impressive. They really did that with partnering with their local leaders, fire chief, police, religious leaders, to really make sure that the communities embrace this concept. And although there's only preliminary data, they have so far provided over 180 referrals to substance use disorder treatment and completed over 1,700 tests for hepatitis C and over 2,300 tests for HIV. So we have 2 briefs on this topic if you're interested, talking about Kentucky specifically and the 7 states that learned from them on our website. So feel free to follow up if that's an area of interest. We also will be launching a new program on this, focusing on New Mexico, because there really is actually a lot of interest from states on this topic. Okay. Wanted to talk a little bit about pain management. So I do think this is an important part of the conversation. This is just a snapshot quickly of the limits. There's 33 states that had some sort of statutory limits on the prescriptions of opioids. 15 states had 7-day limits. This is certainly most common and follows the CDC guidelines. 4 states had 3 to 4-day prescription limits. This is more rare. And then there's 7 states where they directed other entities to set prescription limits. And then there was some of those states, just a few of them, 4 of them, set dosage limits, where they actually looked at the milligram equivalents or MMEs. So that's just a snapshot of what the states have done on that. But I think what comes next, and this is really just a continuum of how states are thinking about it, is, okay, you're limiting the first-time opioid prescriptions. There are exceptions, of course, for certain types of chronic pain and cancer and that sort of thing. But then there's also, how do you promote the clinical guidelines for safe prescribing? How do you think about transforming pain management in and of itself? And then how do you expand access? So I think these are the 3 areas where we're going to work on as we move forward. And just very quickly, I think we talked a little bit, the presenters before talked about, and Ken in particular, about acupuncture, and there isn't a lot of evidence necessarily on these structures, but states are starting to experiment. So I just want to highlight quickly that in Ohio, in their Medicaid program covering acupuncture and chiropractic services, and then in Rhode Island, they have Medicaid communities of care, where they're providing access to chiropractic care, acupuncture, massage therapy, along with access to nurse case management. I think the takeaway from this, and we will have a paper coming out on this as well if this interests you, is that states are stepping in gingerly and carefully in terms of the coverage of these services, sometimes only for certain indications like low back pain, because it's not completely clear on the evidence. But I think there's a real interest in figuring out how do we have alternatives to opioids to actually help people with their pain. And with that, I think I'll turn it over because we are running short on time. So thank you, Catherine.
Thanks, Hemi. It's so important to learn about some of the best practices using technology to connect people to treatment, such as the TeleEcho program you described, to really continue to inform new efforts to link people to virtual care for opioid use disorder. And we had a few questions come in already on that, and we'll start our Q&A session now, so encourage our audience to continue to submit questions, but wanted to open it up to the full panel about, what can be done to make treatment more available to people, telehealth options for substance use disorder treatment, in rural areas, but also, in urban areas as well. And make sure you all come off of mute too if our speakers have their phones on mute.
Sure, I can start. This is Carla Haddad. I mean, I think you've hit a few of the key points right there in terms of really ensuring we continue to increase access to treatment for those with opioid use disorder. Telehealth has been a big focus for the department, specifically at the Health Resources and Services Administration, or HRSA. They have a whole office dedicated to the advancement of telehealth, and we've been making great strides in expanding telehealth services in remote and rural communities that otherwise, don't have access to providers or clinics nearby. So that's been one area of focus that we've been prioritizing. Another one is utilizing and leveraging our HRSA-funded community health centers across the country. I believe there are about 1,400 community health centers across the nation with over 11,000, sites specifically for folks who do need access to treatment to be able to get affordable treatment there, and really ensuring that behavioral health services are integrated into primary care services in those health centers have been another focus of ours. We've put a lot of money toward that effort. And I think more broadly, making sure we're attracting a strong workforce in this area and putting them in the right places, right? Directing them to communities that have shortage designations for behavioral health providers, and also getting a better handle on what our current kind of supply and demand will be in the future, and thinking through how we, one, attract prospective providers, to the workforce, and also thinking about what education and training we need to be providing them with so that they know how to treat and feel comfortable treating people with this disorder. Thoughts from me?
Yeah, and this is Hemi. I would chime in. I completely agree, Carla. I think those are great observations. One of the things that the states have really been focusing on is, at least the ones we've been working with, is the partnership with the communities. Really understanding, I think, from a data perspective, what is happening sort of at the local level, so then you can understand what's needed to actually address those areas that are hard to reach. And, there are differences between those things, right? In some cases, you don't have enough buprenorphine waiver doctors, for MAT. So that's going to have to be the strategy. In other places, there's, in like a rural area, there may be access to just, even the critical treatment at, at a more intensive level, there's like a hospital that's farther away. In other areas, it's making sure your local law enforcement understands the strategies. And, with our work in Kentucky, where we really learned a lot about their syringe exchange programs and how they set those up with their communities, it was when they did that and then they had to figure out what was the referral to care, it really catalyzed some of the work at the local level and understanding where the funds should go and how to partner with people effectively. Because I really do think this epidemic, it has to start with the communities and the states there to support them, and so is the federal government. But it really has to be a community-based approach if we're really going to get our arms around these hard-to-reach areas.
Great. Ken, do you have anything?
Yeah, I'll just say we added a telehealth benefit to the million or so people that are fully insured, and we've been encouraging all of our self-insured accounts to add telehealth as a benefit. So I'd say we're over 50% of our members have access to telehealth, and that's something we continue to want to advance.
Great, thank you. A follow-up question on NIS. We talked a little bit about it, but this person was curious if the other speakers could elaborate on anything that they're doing, either at NGA or through Blue Cross to address the neonatal abstinence syndrome.
Yeah, this is Hemi. I'm glad to speak first. Actually, I was going to talk about it, and I just, so now I can talk about it now. I have the opportunity. So NES has definitely been something that has risen to the top for us in terms of priority area. It was on my list of the 9 areas or 8 areas that we're working on. And I failed to elaborate on what we are doing. And so we did a project just last year on this because of the interest from state leaders. And we highlighted Ohio, and I know the federal government has also been looking at the Ohio Moms program, where prenatal care is coupled with opioid maintenance through MAT in a maternity care home model. And I really think the focus on maternity care home model is really important. And so during the prenatal phase, the program supported the pregnant mom understanding what she needed in terms of medication, understanding the support, social supports as well, not just the sort of medical clinical side. And then it moved also into the postpartum phase, where they offer behavioral health care services, health education, classes on baby care and parenting, and ongoing medical care for mom and baby to keep them together, because as we all know, opioid use disorder is a longer, chronic, more of a chronic need for a pregnant woman, and what happens after she has the baby. And one thing I would say, learning from that program, we brought a number of states to learn from Ohio. There are some states that still have legal requirements on their books where the pregnant moms are really fearful of going into programs because they won't, and there's a stigma associated with, like, you're a pregnant mom and you're using, kind of, why would you do that? And I think there is renewed understanding at some levels, but I think more education is needed to really make sure that the pregnant women feel comfortable coming in for treatment. I also think I would just comment that there's also the longer term, and for non-expansion states, this is more of a challenge of how to provide coverage to some of these populations after they have the baby as well. And it's a really important component of really looking at the disorder more comprehensively. So I'll stop there.
Yeah, from a Massachusetts commercial plan perspective, we support MCPAP for Moms, which is the Massachusetts Child Psychiatry Access Project, which is child psychiatrists consulting to pediatricians. And this is a variation on that child psychiatrists consulting to obstetricians. And any person in Massachusetts who is a provider can ask for a consultation with experts in the child psychiatry space. And that is an effort to try to make sure that all varieties of vulnerabilities that happen in infants and children, have specialized consultation. So we support that endeavor, and we think it's a positive.
Great, thank you. Ken, you had mentioned that really interesting theater program and working with middle school students, and a follow-up question for all of the speakers are, what suggestions do you have for preventing opioid use, misuse, and abuse among children and adolescents? And are there other programs out there that anyone would like to share?
That's a really good question. This is Carla. I can touch on a couple of, initiatives that we've been focusing on at the department level. And we are very focused on, and we very much recognize the issue of stigma. Stigma in communities, stigma, among youth, among providers, and just more broadly. And one initiative that CDC has been focused on over the last couple of years in particular has been really getting the word out about addiction and what opioids can do to you when you misuse them, has been through their awareness campaign. So they have an RX awareness campaign that was piloted in a number of communities and states across the country, and there were some pretty positive outcomes that we saw from those campaigns. So I believe they're now expanding them to be more nationwide. So I think, again, getting the word out through these types of awareness campaigns, television ads, et cetera, has been one effort we've been taking. And I think even beyond the HHS level, at the administration level, the White House has put out the Truth campaign as well, which, again, gets the message across and is focused on peer-type stories, so stories of folks who were addicted but got out, but just kind of sharing the powerful stories from people who experienced it themselves. We found that that's a way to really get to the youth across communities. So that's one area. And we have also, the HHS has been collaborating pretty closely with many different departments across the administration, but we do meet regularly with the Department of Education, and I know they have some specific activities underway in the opioid space.
Yeah, that's great. And this is Hemi. From a state perspective, it's interesting. I think the states have been so focused on the treatment piece because of the overdose deaths. They have been thinking about prevention, but it has been a lot in the prescribing that I talked about, really, setting the limits, because I think some of their data was showing that a lot of the addiction began with, a prescription for, someone hurt their back and whatnot, especially amongst sort of the younger population. And so really, from our perspective, that has been most of our work has really been focused on, okay, like trying to change the initial prescribing practices to ensure that, all populations, including, those that are younger, don't fall into kind of any sort of addictive pattern. So that's just sort of our perspective at NGA.
One thing I'll say, I was at one of the presentations. I've been to many of these presentations. This was in a rural town in Massachusetts, and the principal of the middle school asked how many kids knew someone who had an opiate use disorder. So we're talking about fifth graders. Half the kids raised their hands. So it's not like they don't know. And then a question was asked, how many of them knew someone who had died from an opiate overdose? And it was about a quarter of the kids raised their hands. And what you realize is this is really impacting this middle school population, and they are aware of what's happening around them. So the question is, how do you give them the tools to understand better, the choices they make and the impacts that they have on the choices? So the programs I highly recommend. It's called Drug Story Theater. You can just Google it, and this gives you an insight into one creative program. I'm sure there are others, but this happens to be a local work of creativity here in Massachusetts. And I was able to convince Blue Cross's community team, to help support and expand the program. And they happily did so once they saw it. So I think, all of us who can participate in prevention activities, it's all to the good, even if it's very difficult to do research to prove things. I think information and alternatives are really important to get out.
Sure. Just to follow up on the point you made, Ken, what types of counseling and support services are recommended and available for family members of individuals struggling with opioid dependence?
On the family side in Massachusetts, we have a program called Learn to Cope, which may be a Massachusetts-specific idea, but this represents a support network for family members. And, of course, by removing all the prior authorizations and paperwork around psychotherapy, we encourage family members to get psychotherapy supports, as they, work to support people who they care about who are dealing with addiction.
Mm-hmm. And just to add to that, this is Carla. One program that I can think of that relates to that question is the Behavioral Health Workforce Education Training Program. So this program, I believe, was implemented 1 or 2 years ago, and the whole concept of it is to equip, again, focusing on communities and the health centers in communities, make sure that we're equipping health centers with not only the providers who are prescribing buprenorphine or providing the treatment that is needed for people with addiction, but also supplementing their care coordination team with social workers and psychologists to work alongside the other health professionals as a comprehensive team to provide the other psychosocial support services and recovery support services for individuals with addiction.
And one thing I just would add, I think those are all so on point. One thing that's maybe slightly different from what the original question was is we've also seen the success of peer recovery coaches and really using that tool to support, the person with addiction as part of the family. And there's, states like Rhode Island that have really been models in how to use those different types of workers effectively. And so I think the earlier question also about workforce ties into all of that.
Great, thank you. I think this question is directed towards Carla because she mentioned some of the data. Do we have a sense of whether the cocaine overdose death increase is cocaine alone or polydrug toxicity because of the way it's coded by CDC? And if this fourth wave is really meth and cocaine alone, how do we ensure the efforts address prevention and treatment, especially in light of the fact that there's no MAT for these drugs?
Right, those are really good questions. So the first one got to polysubstance use, I believe, right? So cocaine deaths and what if we know what proportion are mixed with other drugs. I don't think we have the exact specifics on that for the provisional drug overdose death data that I was referring to that gets published by CDC on a monthly basis. But we do know, based off other data we've seen, that a very high proportion of deaths due to cocaine and methamphetamine are also mixed with other drugs. So polysubstance use is a big issue. I can't say off the top of my head, though, the past data that we have, like what exact percentage there is, but it continues to be an issue. And I think it might be actually included in a report that CDC released on the 2017 overall findings in terms of what they saw related to drug overdose deaths. So that information might be there. And in terms of the second question, can you please repeat that?
If this fourth wave is really meth and cocaine alone, how do we ensure the efforts address prevention and treatment, especially in light of the fact that there's no medication-assisted treatment for these drugs?
Right. So yes, that's a really important comment. And again, in the last couple of months, the department has been very focused and committed to addressing, the resurgence of meth and cocaine-related mortality before, again, it becomes kind of the new wave of the crisis. And we've had some internal discussions with various agencies across the department, talking to the National Institute of Health, CDC, of course, FDA, our Centers for Medicaid and Medicare Services, just to come together and think through collaboratively what we can do, what the issues are, right? The issues are that there is you're right, there's no medication-assisted treatment for meth, and that's scary. So thinking about NIH and the research they're conducting, just exploring what else can be done in the research space to get a better handle on whether there are they can put research toward identifying new treatments in this area. And again, discussions are underway internally, but we'll have more to share in the coming months on this.
And this is Hemi. I would just chime in that that was a great question because it's exactly what I think the states that we're working with are thinking about and really challenged by, like how do we really address, methamphetamine and fentanyl and kind of the mixture with cocaine and all of that. I would say the couple things that we've talked about with states fall in a couple of categories. One is there are certain pillars of the treatment and recovery spectrum that they've been building out for opioids that could be transferable to these substances, and one is like a peer support network. Another is a psychosocial support, really thinking about, how, is there cognitive behavioral therapy, what is the support that the individual will have when they're actually going to go into detox and come off. But I think states are still thinking about, without having MAT, what is like the evidence-based practice that they really should be circling around. And I will just, since we have Carla on the phone here, thinking about how federal dollars can be used more creatively to address these other substances. Obviously opioids is a part of it, but as you're building infrastructure, can you build infrastructure that's flexible enough to actually address these other substances as well? So.
Right, that's a great point, and we've definitely been having those conversations at this level as well, recognizing, of course, we're going to be continuing to focus on opioid addiction and the opioid crisis in generally, but in addition to that focus, we have to get a handle on other emerging trends before they take over and before it's too late to really get a full handle on it up front. So we do understand that, you know, it's difficult for states, especially with the state opioid response funding that's, you know, significant amount of funding going to states. Unfortunately, that can only be used for opioid-related prevention, treatment, and recovery services. So we're just trying to think internally about how we can create some more flexibilities in terms of the funding that we're providing states and communities with, so that they can use you know, specific funds to better address the specific needs of their communities.
Yeah, and I know, you know, and I'm sure you all have been talking to, you know, congressional leaders on this to kind of, you know, think about what does, you know, Cures 2.0 look like, and, you know, what can we think about in terms of looking at these other substances. So appreciate your partnership on that.
Absolutely.
Great. We had a couple questions come in about initiatives specific to the Medicare population and what work is being done in that population, both for, you know, mental health treatment and opioid use disorder, and sort of, you know, what's being done sort of to monitor some of that population that, you know, is withdrawing from opioids, and also like what's happening with the death rate specific to that population.
Oh, this is Ken. I'll take a try at this. You know, the benefit changes we made across the board, unless Medicare had specific rules. So the effort we made was to go across the board. Massachusetts does have a Medicare population. If you look at the population of people with opiate use disorder, it really does run the gamut, from the teens to the Medicare population. But our number of members with Medicare with opiate use disorder is relatively low, just per square population. But it is an issue for that population.
Yeah, and I would just chime in, this is Hemi. I think there have been, at least from our state perspective, some states that have really done an admirable job with the data that they have, and really, you know, getting down to a much more analytical level of like, okay, where are the deaths occurring, who are they, who is going to withdraw, what are the clinical indications when they, you know, if they were in an ED or outside of an ED, what can we glean from the records? And some of those states, and I'll just call out one, there's more than one, like in Arizona that has a very public-facing dashboard that has not all of this information, but more of the information out there. And I think it helps the public to understand a little bit more about what's happening with the epidemic in that state. And so there's other states that are doing it as well, but not all states are doing it. But I do think it's a best practice, and really thinking about how to use that data. And data flows not just from the medical side, but also from the public safety side is important to kind of to marry the two. So the public safety people have some sense, as well as the medical people. And I think that's hard, right? It's two different, I'll just use the word silos and systems, and really merging those together, I think, has been a challenge, but some states are really tackling it.
Great. Question for Hemi, are there any efforts to create training for drug court judges on the best practices with MAT, so that they aren't interfering with a doctor's orders for someone who has opioid use disorder?
Yeah, that's a great question. And in our Massachusetts project, they have done, I think, a really good job with the drug courts. And so we certainly highlighted the practices that they used in that setting. And I will tell you, just anecdotally, at the MAT workshop that we had this week, we had a judge come in and talk about how he learned about this. And so, you know, we don't train the judges directly because, you know, we don't work with them in the judiciary branch necessarily. But I think really we've been trying to partner with our executive branch folks in sharing with them that this is an important aspect of the whole piece, the whole puzzle of how to get folks kind of, you know, out of the jails and onto recovery. So great question, and we're doing some work. But if this person has any suggestions for me, you have my contact info. So feel free to send me more ideas.
Great. Question for Ken, but for any of the speakers, can you talk a little bit more about the role of employers and how you're educating them on the ways to address this issue with workers, especially in industries like you mentioned, the construction industry?
Yeah, so our perspective was, a lot of the communities are engaged, but just given my vantage point from the health plan, it did occur to me that employers represent a whole other way to engage their employees in this conversation. One of the things we did at Blue Cross is we had an event where people in recovery talked about their experience of being in recovery. And this was, an event that I think had some people approaching the issue with some trepidation. So I'm just speaking about our own employee culture. And this event could not have gone better. We had 4 individuals who talked about what their life was like in recovery. And I received emails from people who worked at Blue Cross who said, I've worked here for 25 years, and today was the first day I felt that I truly belonged here. The number of people that were moved by the idea of having conversations about recovery. So that's just one employer group. It happens to be my own, but, that was an effort to really impact the culture around the acceptability of seeking help. So the employer groups, we've done multiple events now with the Association of General Contractors, with the Bankers Association. There's a lot of banks in Massachusetts, a lot of public restrooms, a lot of vulnerable people, come into contact with these public agencies. We're looking at some of the larger franchises that have public bathrooms. So to me, this is an area that we have to continue to investigate, where we could do more. But I will say the construction industry has been overwhelmingly positive with the idea that the health plan is trying to help them make a difference for this.
Great. Another question for the full group, and a lot of your organizations are also doing a lot around social determinants of health, and how does that intersect with your work on opioid misuse disorder? Are we sending people home from treatment without housing, without food, and kind of what can we do to better address these issues?
Yeah, that's a great question. I'm glad to start. This is Hemi. So in some of the work that we're doing, just for example, around corrections and reentry and MAT, one of the things that came up, for example, was ensuring Medicaid coverage for people, it's in an expansion state, Medicaid coverage coming out of, the jail or the prison so that they get access to services, but then not just the medical services, also ensuring that they're linked to social supports. So, that I think has been a very clear push and interest from the state level. I'll also say kind of outside of the correction setting, we've gotten a lot of questions about recovery housing. And how do we think about recovery housing, because that seems to be one of the, big challenges when you're actually getting people on a successful path to recovery, is having them have stable housing. So we've done, of course, a healthcare's housing project, which I think intersects with this area of opioids. It's one of the populations that I think states want to focus on. And, figuring out, what does Medicaid play in terms of, allowing, coverage for the supportive pieces of housing, and then how do you then also partner with your housing, agency and, private developers and all that to think about where do we have affordable housing. So I do think there's lots of links, and there needs to be lots of links in order to really think about recovery more holistically.
Right, and to add on to that, this is Carla. At the HHS level, we have been having a number of conversations with our sister departments of Housing and Urban Development and Labor to get a better sense of what the needs are still for expanding the wraparound services that are available to ensure that folks who have treatment also have access to housing and job placement as well. So that's something that we are continuing to work on with our other departments, but that has been also another focus of ours in terms of making sure that people who are entering health centers and other facilities for treatment are also provided with psychosocial services and other kind of broader recovery support services to make sure that they receive the comprehensive care and treatment that they need.
Great. Well, thank you all. We are out of time. I know we didn't get to all of the questions, and there was a few data-specific questions, so we'll try to follow up for people that had kind of clarification questions. But I do want to thank our excellent panel of speakers for being with us today, and thanks to our audience for also joining us. We hope that you found some interesting information to take back to your communities. We'd appreciate it if our audience could take a moment to share feedback from this event by completing a brief survey, which can be found on the bottom of your screen. And we also would just encourage you again to view previous webinars in our Defying Despair series, along with our opioid infographic, and hope that's all useful to all of the important work that's going on to address this important issue. So thank you all again for joining us today.